Good afternoon. It's really wonderful to see everybody here this year for MetaECHO. It's one of my favorite things in the world. For those who don't know me, I'm Jessica Jones. I'm the Director of Research and Evaluation at the ECHO Institute here in Albuquerque, New Mexico. And I'm here to introduce briefly our plenary research panel today, titled The Ins and Outs of ECHO Research and Evaluation. I am very excited for this conversation among some of our expert researchers in the MetaECHO community. In my role, I often get asked questions about how we can make evaluations and research on ECHO happen, or how folks can get involved in research. And our panelists have some great ideas to share with you today. So please join me in welcoming our panel. Our moderator is Dr. Jennifer Krasniewski from Pennsylvania State University. And our panelists are Dr. Kristen Sohl from the University of Missouri, Jane Zhao from University Health Network in Toronto, and Dr. William Callow, also from Pennsylvania State University.
Thank you so much, Jess, and thank you so much to Dr. Aurora and the entire ECHO team for a fantastic conference so far, and much more to come, I know. We are absolutely delighted to talk with all of you today about some of our passion, which is research with Project ECHO. So for the next 45 minutes, you're going to hear some of our conversations on this topic, with plenty of time at the end for your questions and answers too. So please start working towards getting those questions ready for our team up here. We want to start by saying that research looks and feels very different for many different angles for different projects. So this is certainly not a one-size-fits-all. I also want to say that the last time I was at MetaECHO, there were 100 Project ECHO papers, and that number is well over 560 today. So research has significantly grown. We could have had hundreds more seats up here to have conversations with all of you and the wonderful work that you're doing. But with that, we selected some individuals who are doing some fantastic things that I know you're really going to enjoy learning about, and give you some ideas and inspirations for next steps for your own work. So, with no further ado, off to our panel. Our first question is a brief lightning round. Please tell us your name, about yourself, and about the research that your ECHO team does.
Hi, I'm Kristen Sohl. I'm a pediatrician at the University of Missouri, and I specialize in development and behavior. And our research is focused heavily on a couple of pieces, actually. So thinking about how do we show or demonstrate ECHO's effectiveness at helping primary care clinicians identify, screen, and diagnose autism in communities related to a very kind of narrow age range. That's a big one. And then the other big one is thinking about how do we look at all of our ECHO participants and whether we are accomplishing our big goals related to reducing bias, increasing access to autism best practices, as well as really thinking about patient and family-centered care. So we call that our minimum data set, and we use that across all of our ECHO autism programs who are willing to use it with us.
Amazing. Thanks, Kristen. Hi, my name's Jane. I am the research associate for ECHO at UHN, based in Toronto, Canada. And the reason why I'm here is actually because 9 years ago, Dr. Andrea Ferlin, the physician and keynote speaker who was on stage yesterday with the lightsaber, she hired me to live and breathe and think ECHO evaluation and research. So I've been doing that for the last 9+ years. We've run a lot of different forms of research. Our key questions involve what is the impact of ECHO? Are we looking at clinicians? Are we looking at patient outcomes? Are we looking at process outcomes? Can we try to better understand what's happening with the hub and the facilitators? So we try to understand this from all these different angles, and we're using mixed methods, we're using implementation science, we're also using different theories to try to think through these nitty-gritty questions. So we'll get to that in a little bit.
Hi, this is William Callow. I am the Implementation Science Director of our Penn State Project ECHO. We have 19 active ECHO series at Penn State. Most of our ECHOs focus on substance abuse, mental health, vaccine communication, and infection control, and other behavioral interventions. We, in addition to delivering our ECHOs to primary care doctors, we also try to engage other healthcare professionals like CHWs and school staff. not only those people, but we also have some special echoes that we call community-facing echoes, and we want to deliver this communication or these interventions also to our people in our community. So I'm very proud that 3 years ago, when the pandemic started, we did one echo series towards the community in Spanish, and that was a really huge success. We were expecting that only a few people from our state were just joining, but we have a lot of participants from all the US and many Latin American countries. In our echoes, we focus on implementation science. That is my job, and as part of the research component, we try to do randomized controlled trials, and we can talk a little bit more about that in a moment.
Well, thank you all for those great overviews. As everyone can see, there's a wide variety of types of echoes and types of approaches. So why don't we dig a little bit more into that? How about you start by giving us some specific examples around research designs that you've done?
Want to start? So we've done a couple of different types of feasibility studies. So where we're looking at what is the feasibility, usability, acceptability of participating in an echo for different types of clinicians. Again, usually focused on primary care, but we do have looked at some others. Also, we have done a randomized a step-wedged randomized control trial of echo autism across Canada and the US. Really, again, looking to see what does it look like if you participate in, one area compared to the other area. Do you see the same results? And then also, I think really not just the feasibility, usability, but then actually looking at what happens when you're learning through an echo, in our case about autism, how quickly or how, we'll go with quickly. How quickly do those clinicians become confident in the skills that they're gaining through the ECHO program, and then in turn start using those, so that self-efficacy of their own clinical practice. So we've done a lot. We've also done some autoethnography, which means we studied our hub team and tried to look at how we were growing and changing over the course of the ECHO itself.
Yeah, I mean, maybe to add to that, so our teams find it really difficult to adhere to a gold standard of RCTs as research. We find that, so I actually forgot to mention in my intro, I work between 4 different ECHO programs. The main one is chronic pain and opioid stewardship. That's with Dr. Andrea Ferlin. We also have a liver diseases echo, we have a rheumatology echo, and we have a concussions echo. All of these have very different etiologies that don't necessarily have a good biological marker. That means that we can look at a primary endpoint for a clinical trial. So when we think about this, we actually really try to aim our target audience for the clinicians and trying to change clinician behavior. We've run a series of focus groups with our clinicians, some of which allow us to better understand what's happening when we develop a community of practice with ECHO. We've also been doing some education science research lately to look at this development of adaptive expertise. So what happens when a clinician is in an ECHO session, they're taking in that knowledge, but then they're able to discern better back when they face that patient, and they're able to make different decisions. So we're actually trying to better understand that science using education science theories. So those are some of the exciting things that we're working on right now.
We at Penn State are involved in a range of study designs, from observational studies to randomized controlled trials. I want to give you a few examples of those designs. In terms of observational studies, recently we launched a Project ECHO specific for weak partners and organizations who deliver DPP programs to the community. So we assess pre and post changes in terms of their knowledge and skills to talk about vaccine communication with their clients. So that was an observational study. We have been heavily involved in randomized controlled trials. For example, a parallel trial that we did with the nursing home ECHO that Jen Kay was the PI. We studied how the delivery of infection control training decreased COVID-19 deaths, infections, and hospitalizations. In addition to that, we're moving to more sophisticated randomized controlled trials, including stepwise designs and including some adaptive models. In that last one, I'm the PI of something that we call HPV ECHO trial, and that's funded by the NCI. We are delivering our ECHO service in 3 different waves, and after each one of those waves, we conduct implementation science evaluation to better understand how we can refine that intervention to improve engagement among participants. So every single wave, each ECHO is improved. The interventions remain the same, but what we're trying to improve is the engagement. That we have more people participating, that they're engaged in key discussions, and so on.
Excellent. Well, I feel like you're walking me through a manuscript. So we've done the background and the methodology. The next thing that's probably most exciting to people are the results, right? So what have you all found in the research that you've done today? What can you share with the community?
So we've found a lot. We've done a lot of different aspects of research in echo autism, but what I can definitely say is, to me, the most important result is that we know that community physicians and practitioners who are participating in echo autism absolutely are gaining those clinical skills to be able to serve individuals with autism or other disabilities in their practices. And we're also getting closer and closer to being able to show with increasing levels of research certainty that they are able to accurately diagnose autism in the model that we have developed through echo autism as well.
Yeah, I would say for our teams, and I think one of the interesting things is because we run a lot of qualitative research to try to better understand our quantitative results, which sometimes we don't get. We don't see the changes in our knowledge skills, or we don't see the changes in the clinical practice. And we try to understand what's going on and why. And I remember one of the very first focus groups we ever ran. There was a family doctor from rural southern Ontario, and she was talking to us about her chronic pain patients, and she was saying, these are my most challenging patients. They may be 5% of my patient population, but they take up most of my brain space. I think about them constantly, day and night, and this is the person that I'm dreading when they come into my office. And we're able to show, with also quite wonderful certainty, that echo is a really wonderful intervention to be able to help these clinicians. We help them better understand, here are different tools, here are different tactics, here are different ways that you can communicate with this patient. And we're able to see those changes.
We at Penn State, we have seen improvement or changes in skills and knowledge about the thing that we teach in those echoes for most of our echo series, substance abuse, mental health, infection control. I want to mention about the HPV echo trial that I'm managing right now. We're still collecting the data, but we have seen some good improvements in terms of vaccine uptake 12 months after we deliver our echo sessions in the primary care clinics that we're serving in Pennsylvania. One of the key features about doing randomized controlled trials is that you have to connect the information about the knowledge and the skills that you deliver through echo with provider verified information data or electronic health record system data. And I think that's quite important when you do randomized controlled trials, because that level of data, the effectiveness data that you want to show that your echo is effective, needs to come from sources outside your echo. So I think that's one of the most challenging part of doing this type of randomized controlled trials. But we have an amazing team, and we have been able to just work on the data.
Can I actually add one thing? So one of our other studies that we were able to run, and we had early funding from our Canadian Institutes of Health Research, which would be the equivalent of the NIH in the US. We were able to actually try to access that patient level outcome data. And I spent years recruiting patients. Dr. Andrea Ferlin had lots of announcements during our echo sessions to say, please, we're recruiting for this patient research. We don't have access to your patient information, but if you can give us your patient phone number and you think that they would be willing to participate in our research study, please give them our information. So we were able to finally recruit 48 patients for this research. We had them do questionnaires for us. We talked to them, so we had patient interviews. We looked at their charts, and we also looked at their healthcare administrative billing data. This was incredibly burdensome. It was not only, it took so much of my time to do, it took our team's time to do, but the type of data that we got, it was really spotty. And it was really interesting because we have a paper that we just put in for a publication, and when we talked to patients about their presentation at ECHO, a lot of them couldn't quite remember that they were presented at ECHO, but they did remember that their clinician had taken the time to talk to them, that they couldn't quite remember the details about ECHO, but they did remember that their specific patient case was being presented to a group of experts, and they felt really validated, and they felt really proud that their clinician was bringing their information up and that they were important enough. And so I bring this up because I think it adds a little bit of different perspective to the really strong, robust RCT data that you can get, but also this different edge to, when we think about patient outcomes, we can also try to approach it in a different way, and some of the findings are actually really interesting. Yeah.
Yeah, thank you all for that. I'm sure that's gotten our audience's wheels turning. And if they're not super excited about doing research on their own yet, I'm certain that there's questions out there about how they might have opportunity to partner or collaborate with research. So what advice or what information would you offer folks in the audience who may be interested in how they and their teams might be part of the Project ECHO evidence-based movement?
Excellent. I would encourage you, we were talking about our panel yesterday was when we were preparing it, and I think of myself as a clinician first and foremost, a teacher after that, and then a researcher kind of by accident. And I think that what I would encourage you to think about is if you're not into quote unquote research, don't think about it that way. Think about how you can measure the impact of your program. So what are opportunities? And so maybe you do partner with another, one of our teams or one of our programs, and then really just start to ask yourself those questions. How would I know if I'm making a difference? And so that's often a good place to start, right? And then you can have great people who have good research backgrounds help you refine that question and really start to think about what do I really want to know? I think that can be helpful. I will also, just while I have the mic, also suggest that we as an ECHO body, a network of all of these different ECHOs, really need to start very concertedly thinking about how can we sing from the same hymnal, so to speak, of the, when a person participates in ECHO, we know that the following happens. They increase their understanding of best practices across the board. So if it's hep C, if it's chronic pain, if it's autism, whatever. So kind of this construct around a minimum data set where really trying to figure out, every one of these people learned this out of this ECHO. Our Missouri Show Me ECHO, Missouri Telehealth Network team does some of this across our state of Missouri, and that's been working well too, but I would encourage us to think about that globally, because I think as we continue to mature as an ECHO global network, when we try to convince funders or payers or policymakers, I think the more we are able to really demonstrate the impact of our global network, the easier that's going to be to hopefully get us very sustainable funding as well as sustainable opportunities to improve the lives of individuals.
Thanks, Kristen. I think that sets me up really well because, I'm a part of, at ECHO Ontario, we're a super hub. So we do a lot of training for all the new ECHOs that are developing in Ontario and Canada-wide, really. I'm the person who does all the research and evaluation training, and I have clinicians coming to me saying, I thought I was allergic to research before I heard you speak. And, now I'm like, maybe it won't be so bad if we just started collecting some registration data. Maybe it won't be so bad if we just started running some surveys or if we wanted to talk to some people. And I'm always really, really happy to collaborate and to, we share our focus group guides, we share our interview guides, we share our surveys so that you can change and adapt them to your needs and change and adapt them to what specifically your community also is wanting to get out of that program. So I would say partner with researchers or look at within your institutions. Perhaps there are people with qualitative research expertise or mixed methods research expertise or health economics backgrounds, and you can actually run cost effectiveness or cost utility analyses. These are all really important in different ways that we can try to understand the wide variety of impacts of ECHO. But I would say first and foremost, for us at least, after we ran our patient outcomes study, we really try to focus on the clinician because we really do think that that's the first touch and that's the first ripple of ECHO. And that's also where we find the most impact.
My recommendation is to start small and be creative. And, if you want to measure, like in my case, vaccine uptake, but you cannot have access for whatever reason to electronic medical records or a large healthcare system, how you can then recruit parents or recruit adults or participants to collect that information, and you start developing your own manuals of operation about if I want to replicate this in the future, this is the type of information or type of staff that I would need in order to collect this data. And you know what? Sometimes, or actually most of the time, this is research. Most of the time, the first try we fail. This is quite important. We fail. So you develop your protocol, you implement it, you fail, and then you sit down and then you work with your team about how we can modify so next time we are more successful. So I think start small, be creative, and I would say look for opportunities to work with other echos that you think have the same interests like you, maybe better capacity for research or data collection. There are many no-cost trainings online that you can take advantage of. If you are in the US, we have something called CTSAs, Clinical Translational Science Institutes. Most of them, we have one or more in every single state, if I'm not wrong. So you can search those websites, and they have online trainings that are available at the language of community partners, which I think is a beauty for understanding research. Take advantage of those resources and see how you can apply those to your echo and be creative.
I love all of this advice. Fantastic. So helping to build the evidence base towards partnering with folks who are doing this work, using the same sort of data models, and then having information that could ultimately be useful by potentially policymakers or payers, demonstrating that value by going right to the patient level of outcomes and bringing those folks in and having that voice be part of that evaluation. And then, William, to your point, collaborating with researchers either at your institution, perhaps neighboring institutions, understanding maybe a little bit more about research. Testing, it's like a patch test if you're allergic or not. Just kidding, no one's allergic to research. But doing that and getting started with that in order to kind of dip your toes in this area. So if I was interested in finding out where your research is disseminated, what answers might I get from your groups? What are the different mechanisms you use to share these results?
So we like the far and wide approach. So we post a lot of our stuff on social media, LinkedIn, we have a newsletter, all the places. I mean, these are published articles, right? We just like to try to amplify it so that it's sharing those best practices, including our own research from our ECHO. But we think it's really important that, again, either the autistic community or the people with disability in the disabilities community, and then also all the different kinds of clinicians serving them have an opportunity to know what's coming out of the work that we're doing. So I guess for me, the standard answer would be Google Scholar or something like that. But we try to take it further than that and put it in our, again, in our newsletters, in our, both our social media and our traditional media, whether that's newspapers or what have you, and try to really help people understand the key takeaways of the findings that we're doing.
Yeah, I would say we do the same. I mean, we come and present at many conferences, early protocols, and then early drafts, posters, talks, until we get to that final manuscript. We always make sure that our manuscripts are open access so that anyone can be able to download and access them and read them. I think that's an important point because sometimes there are just these paywalls and you just can't get past them. I think one thing, because you mentioned policymakers, Jen, and it's really important to mention because recently we also received funding through our Echo Chronic Pain with Dr. Andrea Ferland leading, a really exciting $2 million 5-year grant that is an implementation science grant. We actually have a diagram of it, and this quite complex beast that you see on the screen takes you through the different phases of our echo research, and we really planned these 5 years to allow us to better understand, one, the history of how echo has spread and scaled, echo chronic pain specifically, through Canada. And then in stage 2 and 3, we're really able to look at, through implementation outcomes, using CFR, which is the Consolidated Framework for Implementation Research, as well as Proctor's framework. We're able to use these different frameworks to help leverage what's working and what are these implementation outcomes that we want to measure, and how do we test one and look at what's working in one echo versus what's not working in another one, and maybe transplant what's working to the ones that and spread and scale these different innovations. And so that's actually part 3 that you see there with little petri dishes. Dr. Chitra Lalu, who I don't think she's here, but she might be watching online, she made this lovely diagram, and it has all these wonderful metaphors about electrical plugs and petri dishes and just testing innovation. And then finally, what we're hoping to do is develop a manual at the end so that everyone who's interested in developing an echo and looking at research, that they're able to access this and they're able to better do it faster and learn from our mistakes.
At Penn State, we use the same approach as social media manuscript and conferences, but at the same time, we have a large presence in our community. For example, we take advantage of state-level meetings of professional associations, and our team goes there with our booth or table, not only to promote the recruitment for the existing or the future ECHOs, but at the same time just raise awareness about what we can offer. Maybe that day that we attend that conference, that meeting, there's not a topic that may interest a clinician, but they know that Penn State Project ECHO exists, and we have offering for all of them. So we have that in addition to this dissemination, that is more at the academic level, we also have this community presence that I think have been very helpful for helping us with recruitment, but at the same time, create awareness about what Project ECHO can offer to these clinicians.
Thank you for those very traditional research answers, but moving into the policy space, and this could be another opportunity for your teams of how you can help disseminate some of those results if you are thinking, gosh, they're behind what we're doing. But this is a great another opportunity for collaboration and partnership. I would say that one exciting thing next month, actually, at the PCORI meeting, they're having a reverse science fair at the Hill. So I have a chance to bring some of our dissemination briefs, which are designed for lay audience, to Capitol Hill and share that with some of our policymakers. So I'll be excited to see how that goes. I've never been to a reverse science fair, and in fact, I don't think I've done a science fair since elementary school, so that should be a lot of fun. Well, we wanted to make sure we had plenty of time for all of your questions, so please start thinking about those. While we're waiting for the first brave soul, no, seriously, you don't have to be that brave. Please ask. We have a great panel here. I'm going to ask them if any of you have anything else we forgot to chat about.
I would just add that I think one of the important spaces that we can start really thinking about is partnering with our participants in research. And so that's something that we are in the middle of doing a clinical trial of a new software as medical device that is really trying to test the waters of how do our learners, so our participants of Echo Autism, how are they able to integrate a brand new discovery out of a different arm of research that I'm not involved in, but how do they use it? Do they like it? Is it effective? All of those things. And so really that then continues to allow us to push that envelope further and further to demonstrate both, frankly, the community participatory research design, so we're really designing it with them and wanting to get their feedback on how the latest and greatest research, so to speak, is affecting them and their practices. So I would just be remiss if I didn't add that element of not forgetting that it's not just your expert hub team who has research or your super hub who's really good at research, so to speak, but it also can be working with your clinicians in rural and underserved communities. Now, fair warning, they are definitely allergic to research, and your institutions are going to be allergic to working with outside institutions or clinics, but nevertheless, the barriers are worth breaking, and I would encourage you to think about that.
Yeah, funny story. A couple of years ago, I had a chart review study that we were running for echo chronic pain. And for the clinic that was a 2-hour flight away and a 2-hour drive on which I saw a bear, that clinic, to get the approval to go and do the chart reviews there, it took a week. We emailed the executive director of the family health team. They said yes. And then I booked my ticket, went up there, and then we did the chart reviews. For the hospital that's next door to us, that's attached to our hospital through an underground tunnel, that data sharing agreement and going through the IRB, that took almost 2 years to be able to go next door and be able to access their patient charts and do that research. So all this to say, these are just different factors to consider when you're thinking about multi-site institutional research. But one of the reasons why I brought up the implementation study with all the fancy diagrams was actually because the leadership is quite interesting for that. So we have, and we had quite specific boxes that we needed to check to be able to even be able to apply for that grant. So the way that our funding agency had set it up was you need a researcher, you need a researcher, you need a clinician, you need a person with lived experience, so a patient partner, You also need a policymaker, and that makes up your quadripartite leadership team. The policymaker that we have as part of that team, he leads the task force looking at chronic pain. So he leads the entire federal portfolio that looks at chronic pain in Canada. He is someone with so many different connections across provinces. He was the one who got us our sex and gender champion. And having these people on your team and being able to build that relationship is instrumental to being able to move forward and kind of push that next frontier of research. So, in addition to having that patient partner and that really engaged, that really engaged research core, we also have that policymaker. So it's really interesting, and we're really excited to see where the next 5 years lead.
Talking about grant writing and grant applications, my recommendation is don't be afraid of that. You will, if you don't write a grant, you will not get it. So I think you have to try. And I think something that I think we as a ECHO committee we can try to do better, if we can create some kind of a repository of examples of funded grants, different agencies, federal funding and non-for-profits and industry, that we can share at least some aspects of those grants, so other people can see those examples. They will see that, yeah, this takes some time. Maybe it's an intimidating process at the very beginning, but if you see some other people here, for example, the people here, we have been successful getting funding to conduct our research, you all can do the same, So I think we can do as an ECHO community, support each other by offering some feedback and sharing our own resources so you all can learn and capture the same level of success.
And talking about collaboration, I would be remiss if I didn't mention our Impact Collaborative. So this is a collaborative like many of the others, but it's not focused on any one type of disease or condition. It's really focused on the research aspects. So we invite you all to be members. This QR code will take you to that site so you can sign up, and it's offered the third Mondays, typically every other month. So I hope to see some new faces at our next Impact Collaborative. With that, I want to make sure we answer your questions. So do we have any questions from the audience?
Ask a question? Okay, thank you. So I'm Andrea Furlan. So one thing that I would like to say is, if you have funds, hire someone like Jane Zhao. My question for the panel, every time that I try to convince someone to do research in ECHO, the barriers that they tell me. So they say, I don't know how to write a grant. I don't know how to get consent. I don't know how to write a paper. So did anyone of you work with graduate students to do this kind of work? And what is your experience? Like, was it good, not good, more work for you, less work? Even working with medical students, I'm approached a lot by medical students who have to do projects. Would you recommend them to getting the ethics approval, writing a manuscript? So can someone answer that question? I had master's, PhD, and postdoctoral too.
I don't have to always start. So I think that the answer to that question of is it worth it is a highly variable one. So you're going to get some students that are just amazing and they can, do all the things. I think that you're going to have the majority of the students have really very little understanding about research. So then that means somebody has to teach them. And so that if that's you, that you need to either add that into the repertoire of what you're going to, your time and availability, or you need to have somebody on your team. So what I would say is, I think that utilizing student or trainee-based resources is a great idea, but as my team would say, we need a system for that. So it's not uncommon for me to get medical students and all sorts of other students to email and ask if they can do research. We have a ton of research going on, but I don't have a great system of plugging them in. So it usually goes like this. Oh, we'd love to work with you. Yes, I'm connecting you to Melissa and to Katrina, and they will help you then. And so what I would say, though, and we've actually been talking about building a better process for that, is having clear, discrete ideas about what the research is that you'd like help with that can get you going. And then also having a clear understanding of what's your bandwidth, how many can you accept, what kind are you willing to have on your team, do you have any prerequisites for them? I think all of those pieces are a really important puzzle. I will say, having done now 15 years of the absolutely you can work with me, not a good strategy, honestly, because what happens is then you end up doing a heck of a lot of teaching. Now, have I built incredible relationships with them and they're all now practicing physicians around the country? Yeah. So was it worth it? Yeah. But in the middle of in those initial moments, I don't know. And so now we're building those systems so that it's not all hands on deck. We got to figure this out because now all these students want to help us process.
I will start with the first portion of that question about the grant writing and manuscript writing. Those are skills that you need to develop over time, and I have been a faculty for over 6 years, and I continue learning about my writing skills every single day. In terms of grant writing, I think one important thing is that we were talking about the different flavors that data can take. It's not the RCT, it's observational data, or maybe it's qualitative data. It's quite important that you collect some kind of data that you can use in your grant application, because many of these grant applications will require you to show that the project that you plan to implement, if funded, is feasible to do, or that there's some pilot data just showing that this can be effective, is implemented correctly. So I think it's not only about those skills about writing the grant that I know you all can develop over time as I continue doing that, but it's what information you need to put in that application that convince the reviewers that your project is fundable. I think that is quite important. Going back to this aspect about research, it's not only about research, it's about how we implement very strong evaluation processes for our project ECHOs. And that's something that is not related to research, but if you want to find funding, but strong process and program evaluation is something that we all in our ECHOs should be doing.
Agreed. No argument from me on that. Other questions from the audience? I see a hand up front.
Am I on? I am. Hi, Dr. Alan Hakim. I'm up here at the back. There's a terrible echo. I apologize. I represent the Earlers Danlos Society and also Indiana University and Penn State. I'm speaking slowly because of the echo. I think I might come down the front. Sorry. We have a lot of experience of participations, increase in knowledge, confidence, the networking. But where we struggle is the next stage, which is patient outcomes, particularly in very complex diseases where there's no singular outcome that you can easily measure. And we also struggle in identifying how these individuals are able to change their practice within their organizations. So my two-part question is, your experience in looking at patient outcomes from a patient perspective in complex disease, and your experience from an implementation science perspective on the barriers or the ease with which clinicians can influence their organizations to change practice.
So an easy one, you're telling us. I'm just kidding.
Super easy
That was a
question.
fantastic question. What do we got?
So maybe I'll take part one and then see where we go from there, because I think it's a really interesting question, and I'm glad that you brought it up, because I feel like for the last maybe 8 years or so, since 2015, we've been using Moore's framework as the evaluation framework for our ECHO programs. It's oftentimes built as this pyramid, going from level 1, where you have just registration data and participation data, going up to these pinnacles, level 6 and 7 of patient outcomes and community outcomes. And I think one of the assumptions that we would like to dismantle is actually that this is a false hierarchy, that if you think about ECHO research as just building up to these patient-level outcomes and community-level outcomes, and you think that the clinician level outcomes that you're collecting aren't that important, then it sets you up to really kind of chase this final goal that may be really, really hard to do, especially if you're looking at conditions like Ehlers-Danlos, or chronic pain, or rheumatology, and, or autism, right? Mental health and addictions. I think there are so many echo programs out here that it's really hard to kind of get that patient level outcome. And when we do, when we ran our patient study, we collected the patient outcomes for pain, mood, quality of life, their satisfaction with their primary care provider. We also looked at whether or not they returned to work and whether or not they were absent or attending work again. And none of these outcomes changed except for their satisfaction with their primary care provider. We saw that go up a smidgen, and that was not statistically significant or clinically significant. And so all this to say is just the type of data that we're able to collect, it's really hard. And when we start looking at also the databases that are available, so one of the clinician outcomes that we were able to look at in terms of looking at clinical behavior change was prescribing patterns. So prescribing patterns for opioids and prescribing patterns for benzodiazepines and other pharmaceuticals that might be used to help chronic pain and its related conditions. And we were able to find, so this is actually, going back to Andrea's question, we had a lovely master's student from Mexico come and work with us for 2 years, and she finished her master's, and what she was able to find was the physicians who came to ECHO, they were able to reduce their, on average, morphine equivalent dose prescribing in comparison to the rest of the physicians in Ontario and compared to a cohort, matched cohort. So we were able to show that the clinicians that came to ECHO, first of all, they were the ones who were prescribing really high doses to begin with. So they are our core target audience. They are the people that we want to change their behavior. And then we were able to show that they were able to change and significantly reduce this after they came to ECHO.
Quickly, I cannot answer the question from a complex disease perspective, but I want to just go back to my own research about HPV vaccination. In my own trial, I'm using Project ECHO as an implementation strategy to deliver the evidence-based intervention called the announcement approach. We know from evidence that the announcement approach training, when delivered in person, in clinics, improve providers' behaviors toward recommending vaccination and in turn improve vaccine uptake among adolescents. What I'm trying to test in this RCT is that Project ECHO is an effective and promising implementation strategy to deliver the same training, same quality, instead of in-person telemetry. That is what I'm trying to study here. For my study, I need to collect immunization data, and for doing that, I'm using patient records from the clinics that I enroll in my own study. Immunization data is easy to get. It's not complex diseases or things that will require a lot of, you get a vaccine and that information is just entered into the EHR. For other complex disease that requires a lot of processes and treatments, it's way more difficult to quantify that in the EHR or to produce that as a patient outcome. So at least for my own study, I'm able just to make the connection between Project ECHO and patient level data easily available at every single clinic. For the second question about implementation outcomes, what I have found is that after each of our echoes, we ask participants to rate the session in terms of satisfaction and our questions. I need more data in order just to understand appropriateness, fidelity, acceptability, and many costs and many other implementation outcome measures. So what I'm doing with my team is that I'm able to collect some of those variables as part of the post-session survey, but I collect other information after those sessions that I incentivize the providers, because if not, they will not take my surveys. And I think I collect that information from time to time. So many of this implementation outcome information in my own studies, they reside outside Project ECHO. I need to collect them outside the usual survey and the usual CME structure that we have. So I think that's how we handle that at least in one of my trials.
And a shameless plug, if you want to learn more about implementation science from Dr. Callow, please join his workshop this afternoon at 3 o'clock on implementation science. Any other questions from the audience? We have time for one more.
Everyone, good presentation. We have colorectal screening program, and for us, it's very hard to track or to measure the impact on the increase of cancer screening from the echo. So I don't know if you have any suggestions on that, and also besides of the surveys, how which other tools we can use to evaluate, because as you mentioned, it's hard to have that feedback through the surveys.
I'm sorry, can you please, one more time for us, colorectal cancer screening feedback to the service, is that the primary care clinicians that you're training, or which group?
Yeah, primary care physicians. So the program, colorectal cancer screening, is focused on increasing the cancer screening. So we don't know how correlate this increasing in cancer screening with the use of echo. So useful is being echo to increase the cancer screening. And the other one was if there is any other tools besides of surveys that we can use to evaluate the echo program.
I'm going to try. So I think I understand the question. So in thinking about how you can measure the, I'm assuming, increase, decrease of screenings, in this case, colorectal screenings, based on the participants that are participating in your echo. Is that kind of what you're thinking? I don't know if you still have the mic, and I can't see you, and I don't even know which side of the room you're on. All right, well, we're going to go with that being the question. So the idea then would be trying to figure out a strategy for measuring their screening. One of the things that we've done in autism is we developed a maintenance of certification, which is just a module that some of us have to have for certification, but where the physician or nurse practitioner participant actually looked at their own data. So they were the ones looking at their own screening data, in this case autism, but in your case it could be applied to colorectal screening, to see, all right, I'm supposed to do this screening at these intervals. Did I do it or not? And then as they participate in echo over time, you continue to have them monitor that screening process. Again, it's self-report, so it's not the most robust research strategy, to be honest. You can also do chart review. That gets you up a couple levels in the research, kind of rung, if you will. But I think with echo, it's challenging to decide how you are moving the needle on patient-level outcomes. Now, in the United States, we have things called claims data, so our insurance companies utilize, essentially, if I write an order as a physician, that generates a bill, if you will, and so then we can also look at prescribers or physicians' patterns of clinical practice through the use of claims data, but depending on where you are in the world, that may or may not be a thing. So kind of, again, giving you that broad aspect or perspective of you can have them do it themselves and start looking at, of the people that are this particular age, how many of them got the screening that they should have gotten, and then does that change as they participate in echo, all the way up to the other examples that I shared.
And I'll add one really quick answer is, I would say add in a qualitative component if you can, because that'll help you really understand the barriers and facilitators of why the screening was done or wasn't done. And then one really quick plug is Dr. Andrea Furlan, Dr. Joanna Katzman, and I are actually giving a workshop on thinking through patient outcomes, lessons learned from Canada and the US. We've actually changed and revised this title. So if you come to the workshop, you'll find out a revised title. It's happening 321 to 350 in room 120 to 130.
If your echo focuses on training providers to improve the communication with patients about CRC screening, and you work in a healthcare system, and then you do the screening in the healthcare system, colonoscopy, for example, I think that's something that you can measure easily. But if you are now delivering, let's say, self-sampling tests like FOBT or FIT testing, that is a little bit more complicated to measure. Like there's a connection, relationship between the echo training and the rates of CRC screening, because the uptake of cell sampling tests requires a lot of things from the patient that maybe your echo is not addressing because it's only focusing on the provider. So I think it's quite important that when you want to measure that, you just make sure that the curriculum or what you're trying to teach to Project ECHO really matches with the variables that you want to address.
And with that, we are at time, but I want to thank our amazing panel and our wonderful audience for your time and attention.